Top Med Talk.
Hello and welcome to EBPOM Chicago. I'm your host, Desiree Chappell, Managing Editor of Top Med Talk, Vice President of Clinical Quality for North Star Anesthesia, and co-chair for this week's meeting. Now joining me is my co-host, Editor-in-Chief for Top Med Talk, Professor of Anesthesia and Critical Care at the University College London, and my co-chair for this meeting, Professor Monty Mythen. Hello, Monty. Good morning.
Hey, Desiree. Great to see you.
Well, we know we're pre-recording this, Monty. So if anyone out there joining us from wherever you are, thank you for participating in yet another virtual meeting. Hopefully, we're all going to be together soon. But if you do have any questions for our panelists, you can always email our admin, so admin@ebpom.org. It has been a little bit of a crazy year, Monty. We are still virtual, and we actually can join two of our big EBPOM meetings this year for the fall.
EBPOM Ireland, which is one of our oldest meetings, going for nearly 25 years now, traditionally been live from the west coast of Ireland, which is where I hope we are now, bringing this to you, and combining that with our EBPOM USA meeting, which in the last few years has been from Chicago. So we've melded those two together, and I hope that's working for everyone. I hope we're bringing you great quality and great value.
If you've missed any of the fabulous conversations or pre-records, you can always find those on EBPOM Education Hub at live.ebpom.org from where you're viewing this. It is our Medtronic lunchtime sponsored session. And we're going to have some great conversation here. The lecture for this particular panel discussion is up on the pre-records. It's by Dr. Robert Thiele. So we have the opportunity, Monty, today to have one of our favorite types of chats here at EBPOM and on Top Med Talk, for that matter, our roundtable discussions where we bring people from the multidisciplinary team, different backgrounds, to sit down and have a conversation about a topic of interest. And today we have the cardiac team from the University of Virginia joining us to discuss NIRS, or near infrared spectroscopy, which we've had some discussion here at EBPOM and Top Med Talk. And so back again, as a friend of the EBPOM family, a fan fave for sure, is Dr. Robert Thiele. Now, Bob is a cardiac anesthesiologist and intensivist at the University of Virginia. He also has a background in engineering, which always brings a different perspective to the table, and we love talking to him. Bob, thank you so much for joining us today and taking the time out of what we know is a very busy schedule for you. So thanks so much.
Thanks for having me, Desiree. Nice to see you again, and you too, Monty.
Well, Bob, we have some colleagues of yours who are joining us from the University of Virginia. Today, we have Carol Ann Rosenberg, who is a perfusionist. She's an associate director of perfusion and ECMO. She also has her MBA, which I'm sure will be an interesting perspective as well. Carol Ann, thank you so much for joining us. You're the first perfusionist that we've had on at least Top Med Talk, and I believe EBPOM. So
thank you for having me. I'm honored to be on. Glad to be able to contribute my knowledge and understanding and use of using NIRS in the OR.
Now, we also have a cardiac surgeon join us today for the conversation. Again, cardiac surgeon and director of the Valve Center and director of Aortic Center at the University of Virginia. I'm Dr. Keenan Yunt.
Thanks so much for having me on. It's a great opportunity to talk about something that we've been passionate about here at UVA.
Yeah, well, I love the fact that we have this team together and we can actually dig deep. I think having, perfusion and a cardiac surgeon here really makes a big difference. So take us through a brief little explanation of what NIRS is and where we might see that technology in the space of perioperative medicine.
Yeah, so NIRS, near infrared spectroscopy, is the easiest way, I think, to explain it is sort of a variation of pulse oximetry. It transmits red and infrared light into tissue. But unlike the pulse oximeter, which really focuses on the pulsatile blood, which is arterial, the NIRS devices measure the absorbance of infrared and red light that's not pulsatile. And so they're able to capture information from arterial, venous, and capillary blood simultaneously. And that calculation gives you what we call a tissue saturation. And the saturation is really an aggregate estimate of arterial, venous, capillary blood in whatever tissue you're shining the light into. So typically we're using it on the brain, at least in the cardiac and vascular space, but people also in other areas like the surgical ICU can use it to measure muscle oxygenation as well.
So people might not immediately think of a clinical utility for that, but I think that Carol is part of your ECMO unit there, for example. And one could imagine that if you have big pipes in a limb, that knowing that the blood supply is getting past those big pipes might be a way that you could use it. I'm loading the bases there a bit, but I'm guessing that's why you might stick it on a muscle, that sort of thing.
Absolutely. We also use it in the NICU as well to look at for neck. So it's got a lot of utility, and it's not just, in the OR. We have started in the OR and then we brought it out into the other units. And so for distal limb perfusion, it's very important. So a lot of times, when you look at it and people are looking at this monitor, they're looking at numbers and they don't necessarily know what they're looking at. I mean, I myself didn't when they first gave the device to me to start using, and they're like, you just need to follow it. You're going to eventually understand it. And I'm like, because it doesn't tell you what's going on. You're just looking at a number, and then you turn around the next time, it's red, then it's yellow, and you're like, what does this all mean? But then as you start to use it, you start recognizing like, wow, I was like 65% regional oxygenation of the limb, and now all of a sudden I'm 20. Something's changed, something's wrong, something's different, and of course you want to look to make sure, is the sensor on correctly, is it connecting correctly with the skin, and once you realize, yes, this is correct, that there is something wrong, and you start dialing with your flow, and is he on too much pressors? So it is the first defense in being able to, I believe, salvage a limb from somebody so that they don't lose that limb.
And if it could, Carol, you said NICU and neck. I think I know what those abbreviations mean, but not everyone listening will do. So could you expand on that?
So necrotizing is just basically when the neonates, when they're not getting enough oxygenation and feeding and stuff, their intestines start to basically rot. Ooh. So it helps pick up, like you're having decreased oxygenation, and it allows us to see something's going on. Why are they not getting that oxygenation to their stomach?
Thank you.
Many of the people watching today come from an anesthesia background, perioperative medicine background. Bob, what are some of the other cases, just really quickly, in the OR that we may see cerebral oximetry and NIRS?
I mean, primarily for brain monitoring, we're talking about cardiac surgery, adult and pediatric, and then carotid vascular surgery. There are also post-operative uses in plastic surgery, for instance, flap monitoring in adults in the surgical ICU, but that's not something we typically use in the intraoperative setting.
Intraop, we also use them for shoulder cases as well. So bench sitting cases as well. That's one of the things we use.
So we don't at UVA, but I know a lot of centers do with the people that are sitting up. There's a low but non-trivial risk of devastating stroke in those procedures. And a lot of people do use them to try to detect that.
Now, we touched on this before, Bob, and I think Carol was just alluding to it for those people who haven't used this technology. A bad number is usually bad, but a good number is not always good. Is that fair?
Yeah, I think one of the key things to remember about cerebral oximetry is that it's only looking at where you put the patches, and that's typically going to be on the forehead. So if you had an occipital stroke, it wouldn't necessarily capture that. Now, this gets into like what causes a stroke in the perioperative environment, and that's not completely understood. Sort of the belief is that it's some combination, often of some atherosclerotic event, calcification from the aorta, and hypoperfusion, and all those things come together to lead to brain tissue ischemia. And so it is true that it's not a perfectly sensitive detector for cerebral ischemia. And the other thing is that it is measuring that sort of blend of arterial and venous blood and capillary blood. And if your hemodynamics change significantly or positioning changes, you kind of have to understand how to interpret the data. If you put somebody in head down or cause venous engorgement, that will make the number go down because you have more venous blood in what we call the optical field. Now, you can get a stroke from venous occlusion as well. So it's challenging to interpret sometimes, and you have to think through it. It's not something you can just slap on. Like the pulse oximeter, you put it on, it says 98%. That means that the saturation is 98%. And as long as you see that nice waveform, you can rely on that typically. There's a little more thinking involved, which Carol Ann alluded to with using this technology, but I don't think that makes it less useful.
We have here, I think, for the first time in our discussions, the sort of Holy Trinity here of protecting the brain and the body during cardiopulmonary bypass. That's Keenan, I know, is going to come in and think, hang on a second, we need to talk about who's directly in control when we're on bypass here. Is it Bob's fault? Is it
not me?
Carol do something? That's going to say we know whose fault it wasn't, but it can be, can't it, Keenan? You can do things that can mess with it too.
Exactly. I mean, I think this is where communication with Bob and Carol Ann is sort of paramount because, particularly here, we do a lot of complex aortic surgery, a lot of redo surgery. As Bob is alluding to, sometimes the head needs to be up to get optimal exposure. Sometimes the head needs to be down. Sometimes I'll put a good deal of retraction on the innominate vein, which can cause venous engorgement. And then if we're circumresting, certain readings may cause me to augment my cerebral protection strategy. If I were, retro or just selective down one carotid, I might choose to go down both. I think also it sort of helps us, particularly when the body's cold and we have two arterial lines, may help us titrate that pressure a little bit better too. And I think it's just constant communication between the three of us as to what's going on to make sure we have a great outcome. Because when patients come to me, at least for cardiac surgery, they're obviously focused on if it's a complex case, what the risk of death is. But I'd say second to that, or sometimes number one to that, is I don't want a devastating stroke. So I think that is this topic in particular is of critical interest in most cardiac surgeons.
You mentioned circ arrest. Now, I'm guessing not everyone understands that occasionally when surgery is not possible, you might have to turn everything off for a few minutes. Yeah.
That's correct, particularly when we're focused on aneurysms, which are large blood vessels, or dissections, which tears into the large blood vessels. When we have to repair those near the arch of the aorta, which is where the brain vessels all feed off of, the only way to feasibly do that is to drain out all the blood in the body and stop it and cool the brain in order to preserve its function. And you don't have forever to do that, but we do some things to selectively give blood to the brain while we do it, particularly in those cases. It's needed. But I'd say in all cardiac surgery cases where we are bypassing the heart, those are opportunities for strokes in my book.
I was going to ask you too, you said for all cardiac cases, where you would be going on bypass, is there a place for NIRS in any of your other cardiac type cases? Say, for instance, like TAVRs and, a little less invasive?
I think so. Even with TAVRs, we sometimes get challenging anatomies. We may have to deliver the valve through the carotid artery, depending on the patient's vasculature. But all of those cases are opportunities for strokes. And frequently, and that can happen before the TAVR is even deployed. And so that may change our strategy, may change which valve we use. If all of a sudden somebody's stats do drop during the case, it may select whether or not we balloon the valve before we deploy the TAVR. May also influence whether or not we augment our strategy with the cerebral protection device. The TAVRs, everybody who has a TAVR, 90 to 95% of folks will have some MRI findings post-op from calcium dislodging.
Yeah, I think that's one of the great misunderstandings about TAVRs is we think of it as minimally invasive, and in many ways it is, but it by far has the highest stroke risk if you look at MRI, and that's based on data from over 1,000 patients that have had surgical AVRs, TAVRs, CABGs, things like that.
In the post-operative phase too, there's the intraoperative risk, but then that extends, particularly with the inflammatory state of surgery. A majority of the strokes we actually see are in the post-operative phase, and sometimes that's difficult to tease out. Some people have had strokes before. Sometimes an old stroke gets reactivated just from periods of hypoperfusion. And so I think that's another potential use when these patients are in the ICU recovering, is augmenting how we detect strokes and really distinguish what might be confusion, what might be delirium, what might be an actual neurologic event.
We're talking here about the placement of the aortic valve for, via a pipe that goes up the leg and then having to blow a balloon up to split the old valve, etc. If an engineer was sitting here, they'd probably say, well, look, you're bound to spray a whole load of goobers around. Can't you put some sort of netting in there to catch them? Or has that not progressed in some way where you can sort of, it's kind of obvious, isn't it, that if you're going to split that valve open, stuff's going to go the wrong way?
Yeah, the first generation of devices had disappointing clinical results. In fact, it's sort of, the practice has largely been abandoned due to futility in the country, but we would put a device up, think of it as a fishing net, that would protect the carotid arteries coming off the aorta. And it would always catch things, but there was no difference in clinically detected stroke amongst the patients who got that. But there was a difference on MRI volume of stroke. So it's hard to know. That difference was significant. The clinical significance was less significant, but it probably does have, those are short-term outcomes, not long-term, for number one. And number two, there was some concern that with the first generation devices, simply placing that net was manipulating what atherosclerotic disease might exist at the base of the carotid arteries where they can't come off the arch, which is where those devices are positioned, that simply in and of itself may provoke strokes. So that unfortunately, there's no panacea for cerebral protection during TAVRs.
Well, switching gears a little bit, I want to look at and have you guys take us through utilization of this technology in a cardiac patient, because I think that really can paint the picture of how we actually use this in practice.
Yeah, so we put these patches on the brain before we start pre-oxygenating. That's based on Matthias Herringlank's data showing that low preoperative cerebral saturations are predictive of sort of bad outcomes. We already have the STS calculations and everything like that, but you always want to know what someone's risk probability is. The more information you have, the better. That number doesn't change whether they have surgery, but it's helpful for us to know. And it's also important because, as we mentioned, this is a trend monitor, unlike the pulse oximeter, which is an absolute monitor. So we do have to set the baselines and try to keep it within 20% of that. That's how we start. No oxygen, put the device on, set the baselines. Then we start pre-oxygenating. It always goes up, go off to sleep. We're putting our lines in, monitoring every part of the patient, including the cerebral oximetry. We turn their head quite a bit sometimes to put the central venous catheter, and their heads get turned with TEE, with echo. And sometimes that will cause a unilateral change in the cerebral sats, and we try to straighten their head to make sure that we have adequate venous drainage. And then an hour or so later, after we've got all our lines in, the surgeons have done their sternotomy, then the chest is exposed, and then we're ready to go on bypass. That's when I make sure that the perfusionists can see it, although now they have digital outputs so that they can actually see the numbers in their machine. We used to have to kind of like push the stand around and knock over the nitric oxide delivery device or whatever so that everybody could see it.
Well, Carol Ann, you have this information for you now, and what you do is such an integral, being on bypass and managing the hemodynamic state of these patients. So how do you utilize NIRS to do that?
We also will use it in somatic with the kids as well. So that's actually another tool that we have where you can make sure you can monitor the split between the head and the kidneys. So when we go on, I always want to make note of like where we are baseline. Where was this patient before we went on pump? Because what I'm looking for is I want to follow the trend. I want to see where I am. And then I need to make sure if I start to drop, my goal is to get back. Can I recover back to where we were baseline? So I want to look at all of my parameters. I want to make sure that I have enough oxygen and CO2, being removed from the gases. I want to look at the pressure. I want to be able to look at, do I need more flow? I want to look at my hemoglobin. So once I look at everything and I want to draw a gas. I want to make sure that that's reading what, my other trending devices are. And I want to make sure that all of it is okay back at the pump. And then at that point, then what I want to do is that I want to go and I'm going to start conversation with the anesthesia. I want to ask, is the NIRS, did it fall off? Is the patient sweating? Is it accurate? Is there something more? Are they light? Do they need more sedation? Do I need to put some more isoflurane on? And then if that's can't solve it between me and anesthesia, then I'm going to have a conversation with the surgeon and be like, did anything change up there? One time I was using it and we were starting to lose volume, but it wasn't really consistently. And so, but my NIRS just were not coming up and the somatic kept dropping. And I'm thinking, what's going on? And, here the venous cannula was too deep. So we were having some venous congestion, pulled it back, everything was fine. So I think that a lot of people, they either love NIRS or they hate it. And it's because you have to be the investigator. You have to figure out, you have to believe in the device, right? And you have to say, okay, I understand that this is where I am. And then now I'm not there anymore. So what changed? Was it something I did? Is it something anesthesia? Or is it something surgically? Where are we in the case that could possibly give me these values?
Carolyn, when you say somatic, what are you alluding to there?
The kidney. So we're looking at the kidney. So with the kids, we're able to do that because, they're not as thick as us adults are. So you're able to get the actual kidney. So that's actually a really great, to me, when you're able to see the cerebral and you're able to see the kidney oxygenation saturations, you can compare, because you always want the head to be a little bit less than the kidney, meaning that, the kidney is a bigger organ. So when I don't have that appropriate split that we started with, I'm trying to get back to why is it the head? Is all the blood being shunted to the head? Is there something wrong? Why am I not giving enough flow to the body? Is the hemoglobin not accurate? I wish that we could come up with a device that we could use it in adults and get the kidney, because I feel like that correlation between the two is so important, especially when we're doing ventricular assist devices.
So for a while, Carol and the others, there was a period of time where thenar eminence, the thumb bed, was sort of used as an adult another place, a low priority part of the body as a reference point. And it had a bit of a sort of heyday in sepsis. You'd put cuffs on and do squeezing tests, and it all looked quite interesting. Has that come and gone? So
I've never used the thumb, but that's a good
just the theme. I mean, I think we helped in some of the research we did to finish it off, but Bob, is it?
Yeah, Monty, I actually was just thinking recently about that, and I dove back into PubMed. And there's not a lot of people studying that or publishing it right now. I'm not sure why. I mean, there's some good data from pigs in cardiopulmonary bypass showing that quadricep muscle, if you don't have adequate perfusion, these are bypass models, you can detect that in the muscles. And why that would be the case in cardiopulmonary bypass, but not sepsis, I don't fully understand. But these are complex, complex problems that we're dealing with. Keenan mentioned earlier, inflammation factors into both bypass and sepsis, and it probably changes the saturation both in the brain and the muscle. And so we don't fully understand it. And what Carol Ann, her description of how she uses it, I think is really illustrative of why some people are reluctant to use it, because you could hear her thinking through, it's not a just easy number. And
it's rocket science.
Well, it's not like it's not.
I mean, let's be fair.
Either, but it's somewhere in the middle. You have to think about it.
If you've got a triumvirate like the three I'm looking at here, who are prepared to talk to each other about the complexities of what might be causing it, to a point whereby you're saying, we might be getting a low-grade inflammatory response here, which is why I can't separate my, peripheral sensors. Then it's a beautiful thing. But if you think of it just like a pulse oximeter, it's not going to help you too much. You've got to have this level of engagement.
The blood pressure can be great and everything else looks great, but your NIRS are not, and they're trending down. And so if you don't believe in the system, then you're really not going to go that deep into investigating. Whereas when it was brought to me in 2009 by a physician in Augusta, Georgia, and they were like, this is going to be your device. You're going to love it. This is going to be the best device that you have on your pump. And so, you start looking at it, you're trying to understand it, trying to do the trends. One day I had a case where everything was great. We were off pump. We were like, this is great. The numbers look great. The kid looks great. Next thing you know, I start to look, we're starting to throw the pump away and the trend is going down. And then the next thing, and the patient's still fine. Next thing we know, the NIRS is reading 15 and I'm like, something's wrong. And then, and everybody, it just was a new device and they're like, what do we really think about it? And the kid crashed. And so from then on, I have embraced NIRS. And so I am like, once that starts to trend down or something's not right, I'm investigating. You always want to make sure, is it on right? Is the patient not sweating? And if that is not a material malfunction, you really need to investigate what's going on, because you could save that patient from harm.
I was just going to say there, another example of how it can be useful is we've had a case you think you put these A lines in, you're happy with them, but these people have really complex vasculature. And we've had cases where the numbers on the invasive blood pressure monitor seem like they're fine, but the cerebral sats aren't. And then you do some digging and measure blood pressure somewhere else, like more proximal, and you find out, no, actually, it's not okay. And we may have been missing some hypotension that we would not have detected if we hadn't had the cerebral sats on.
That points to sort of, and these are pipes that we're using. They're subject to positioning. Caroline spoke about the venous cannula, but I've seen cases where the arterial cannula, wasn't maybe directed where the surgeon thought it was when they're doing an arch case. I had to come in and correct that. And then also, as Bob alluded to, if you're measuring pressure and, on a dissection, ideally you'd have A lines and both extremities, upper extremities, because there could be a huge difference if there's a tear in the aorta. It may be falsely elevated if blood flow is cut off to one or the other. So I am a big proponent of it in that sense. And it does force me to at least make sure and troubleshoot my field that the pumps are okay, that my retraction is okay, that my cerebral protection strategy is sufficient. But it definitely does take troubleshooting.
In all forms of surgery, the technical capabilities and decision-making of the surgeon are very, very important. But I always say to my teams wrapped around that, we can't make bad surgery good, but we can sure as hell make good surgery bad. I'm loading the bases for you there, Keenan, but is that a fair comment?
I think so.
Easy.
Yeah, I was just going to say easy now.
Well, you've got to be prepared to face up to both options as a team.
Anesthesia and perfusion are incredibly humbling disciplines for sure. I mean, I think what you're getting at is that I agree with you. I remember my last day of my fellowship working with a very experienced cardiothoracic anesthesiologist. And he said to me, like, I've been doing this for 25 years and I continually still brought to my knees about how hard this job can be. And you're right. So anything we can do to make it a little bit easier or understand the complexity of what we're doing, I think we should do. And, the patients that we operate on now are so much different than the people that had heart surgery in like the 80s and 90s and early 2000s. I mean, with all the stents and the people that actually make it to the OR now are just really, really, really sick and complicated.
Yeah, all the easy ones are going to the cath lab.
Yep.
we get stuck with everything
else. The ones that are going
else.
to surgery are end-stage disease.
Yeah.
And so they're at much higher risk for all these things we're talking about.
Let's go back to, again, kind of the pathway here. And coming off pump, I always felt like was one of the most challenging times. I mean, obviously it is just to balance everything, but really one of the most challenging times where I felt like NIRS was really useful in that space. So, how do you guys use it coming off and managing the hemodynamics at that point?
Yeah, I would say that there's a whole lot of hemodynamic changes coming off bypass, and that transition from a sort of exogenous source of blood pressure and flow to back to the native circulation can be tricky. Any piece of information you have is helpful. I think that we're monitoring those cerebral sats when we're coming back off, because now I'm monitoring because hemodynamics is now my problem. Like when we're on bypass, I'm watching, but it's really about Carol Ann and her team. I'm helping any way I can with vasopressors or whatever, but the ball kind of comes back to my court when we come off bypass. And I want to see, we're still looking at trending the cerebral sats. And the two things I would say we do are we look at the blood pressure and how it affects cerebral saturation. There's a lot of research that was done at Johns Hopkins from Chuck Hogue, who's now at Northwestern, showing that, you can really build a pretty reliable cerebral autoregulatory curve if you look at blood pressure and cerebral sat and just kind of map them out. Now, I don't write that down and put it in a spreadsheet, but you can kind of see, like, I just bumped the pressure up 10 millimeters of mercury and the cerebral sats went up. That was probably a good thing. Or, conversely, we don't want to work the heart too hard when the cross clamp just came off. There's a potential for reperfusion injury. And so we don't want to flog this newly revascularized myocardium or whatever. And so if we can live with a map of, 65, 70 and the cerebral sats are fine and not have to put the patient on rocket fuel, that's a good thing too. And I think having access to that brain saturation in the context of 3 hours of surgery and knowing their baseline helps you a little bit to do that. The other thing that I like is that sometimes after cardiopulmonary bypass, the pulse ox actually just doesn't work in VADs or in long pump runs or whatever. And if you don't have cerebral saturations, that's a really challenging sort of situation to be in, because you're really trying to make sure you have adequate oxygenation to tissue. And if you're on high dose vasopressors or you have a non-pulsatile circulation now, the pulse ox won't read anything, or if it does read something, it's going to be a fake number. But if you have the cerebral sats on and they're 70 and they start out at like 55 or 65, that you don't have hypoxia and that you don't have arterial hypoxemia, because if you did, that number would be quite a bit lower.
Yeah. I always felt like coming off pump was a bit of a dance between everybody, and we're all twirling around with different, our different partner and who's doing what and making what move. Carol Ann, I always felt like we had to be really tuned in, with perfusion to make sure that we're coming off pump. What does it look like for you?
I feel like it's a snapshot as to whether or not we're going to be successful, right? Because I have the luxury of manipulating flow. I'm like, oh, you need more flow? Here's more flow. You need more hemoglobin? We're just going to drop it in. I've got a huge reservoir, like a bucket. So we have a lot of tools that we can use, but you got to hand that patient over to anesthesia. And so, a lot of times, especially, when you work at an academic center, you're dealing with the right heart. The right heart's not very good. So you really need to say, like, I can't overfill that heart, but I know that patient needs more volume. I know that patient needs more hematocrit. And so, it allows us to be able to have that communication with the anesthesia. You're like, okay, this is what I'm seeing coming off pump. We didn't add any volume when we went on pump, but I still have like 1,500 mLs in my reservoir that need to go back to that patient, but the right heart's not looking great. The NIRS aren't looking great. And so it helps us try and predict what we might need to be successful to do that transition.
When you're using your somatic monitoring, your renal monitoring in smaller people, do you see people making different decisions when they come off bypass? If they see that the heart-lung-brain circulation looks great, but the kidneys are getting nothing, is it affecting their management patterns?
So a lot of times, like, we'll see it. So because the kids are so small, it could be that a cannula is obstructing, right? And so like if we're muffing and you can see that it's starting to trend down, or maybe we need to get the nitric in, right? Because the vascular bed is, the pulmonary needs, nitric. So it kind of helps us to see, because a lot of times, like, you'll see when you're, we do a lot of hypoplastic left heart reconstruction, a lot of aortic arch, a lot of pulmonary issues. And so it allows us to see that, we may be up against some challenges here, and that we need to get nitric down sooner than later, or that the hemoglobin, it's easy. The other day we did a 2.3 kilogram kid, you give them 15 mLs of platelets and 15 mLs of cryo. The next thing you know, your hematocrit's at, 29, and it's a single ventricle. You want to try and get that up, and you'll see that immediately. And that's when I'm like, what's the hematocrit? Can we get a blood gas? So, if it's a lot of investigative work, but it definitely can help and save the child, because you don't want them to crash. You don't want the adults to crash because, you're giving them too much volume. You're going to start to see it because the right heart's not going to go very well.
So we need to get Bob and Keenan something that works a bit. It's been a holy grail now for, 30 plus years to get something for the adult that allows you to look at another part of the body reliably. Bob, go at it. You did a degree that should solve this problem.
Hey, there's a lot of work now with coming back with renal oxygenation. Mark Stafford Smith taught me about that in my fellowship. The partial pressure of oxygen in the urine actually does seem to be reflective of renal medullary oxygenation. So that may actually be on the way. Wow. Hopefully.
There is one device out, I believe, it's approved in Europe. It's an oximeter adaptation of a urinary catheter. And they've gone for the surface receptor just at the junction between the bladder and the urethra, which is a poorly perfused area. And my colleague Mervyn Singer is in late stage evaluation of an in-bladder oximeter. There are other things around. But
bladder NIRS, I like it.
Yeah, exactly. But the gut's the answer, and tonometry worked. Just, we've got to get it back off the shelf.
Yep.
Because AKI is huge, and a lot of times, they either may be coming with it beforehand and we haven't caught it, but then as soon as, they're done their surgery, now they have it. And so you're like, hey, I saved your heart, but, you've got dialysis, looking forward to. And so I think that that's hard. And, with DO2, being able to see how much oxygen we're delivering to the body is another great trending tool that we have. But then coupling with NIRS, and if we can get a NIRS somatic for adults, I think that's even going to be more valuable.
I was just going to say, we actually built a prototype to do esophageal NIRS a couple of years ago. And the idea was that
that's pretty good.
We have a TE probe in everybody. So if you could actually have the NIRS on the TE probe, you could be measuring esophageal tissue oxygenation while you're doing these cases, because you're already inserting the probe, so it's no extra risk to the patient. And I have a probe in my lab. I just need to get back down to the pig lab and test it.
The lower third of the esophagus is similar to what you'd get from gastric tonometry, because, the foregut and the hindgut develop differently. But the lower third is that's the bit that ulcerates. Get dusted off, Bob. Come on, we're giving away all the best ideas here. Live on TV.
Yeah,
But
you
if you
guys,
look up,
you guys are going to be seeing
it's all
something
been
soon.
patented before. But
Yeah, I mean, at this point, I don't care who gets the money or develops it. I just want it to happen.
Just give me one.
Just
Give me
want the
one.
tools.
Yeah.
That's right. Walk us through that aha moment when you thought, this is something that is going to be very valuable and that I can use in my practice and make sure that we use on our patients to make a difference.
I can recall one case where, in fact, I teach a lot of surgery, and when we went on bypass, the cerebral sats dropped, and you teach a lot about how to put cannulas in and stuff. But I remember I ended up having to take it out and redirect it. At that point, had I just ignored it and said, it's fine, that patient would have a devastating neurologic outcome. And as a result, they had no adverse outcome. And I think that is really certainly helped me adopt it, was seeing that. And probably things like that happen more than we realize.
Yeah, I had a case. It was a circ arrest case at UVA. I don't remember who the surgeon was. May have been Keenan. And when they started using their retrograde perfusion strategy, we got a big unilateral difference in the cerebral sats. And we did everything Carolyn talked about, ice packs on the head. And so we're like, pull that back. They're on fine. We told the surgeon and the perfusionist about it, and they switched to an antegrade strategy, and it shot right back up to normal. I just know that a cerebral sat of 19% is not compatible with brain health, and that changed that patient's outcome. I know it, and I don't know how we would have known if we didn't have. There's no way we would have known if we didn't have the cerebral oximetry on.
And Carolyn, you said, there are people out there, and we all know for this team that there are definitely cardiac procedures that are being done without this. For you and specifically your perfusion colleagues, but everyone listening in the perioperative space, what would you say the value of this and how may, we use it more and really start to adopt it if you're not already?
Think that it gives us, like I said, you have to be able to be investigating. So you need to be able to take all of your skills that you've already learned and apply it to utilizing this device within your program. And, I think in the end, it saves lives, and it will allow us to be able to save limbs. We think, everything, when you look at the numbers, when you look at a patient, you walk into a room, everything looks great. The flows look great. The pressure looks great. The pulse ox, like Dr. Thiele alluded to, looks great. But in the end, you're looking at NIRS that are reading like 19 and 15. You're like, something's not great. I mean, we had a ventricular assist pediatric patient that was waiting a heart transplant, and the NIRS weren't right. The somatic was reading a lot lower than the head. And I'm like, guys, we're not giving enough flow to the lower body. And I'm like, we need to increase the flow. But when you look at what that child should have gotten based on the cardiac index, but, not everybody goes by these numbers, and that they're not always like one flow fits everyone. And so it allowed us to think like, yeah, we do need to increase the flow. We increased the flow. And, I really do believe that we saved that child's life and was able to get a transplant because we were thinking that things were going wrong, but it was flow. And so I encourage people to get out there, to use it, to research it, to understand it, and to adopt it in their practice.
Yeah, I would just say to anyone who's listening and works in an ICU environment, also don't forget about this up there. We didn't really have time to talk about this, but Keenan mentioned it earlier. A lot of the cerebral desaturations that occur after surgery actually don't even occur in the operating room. They occur in the ICU environment. I think that's a huge opportunity to take better care of these patients. If you're putting them on everybody in the OR and then you rip them off when you take them upstairs, but then most of their hypoxia burden is actually going to be in those 48 hours in the ICU, then it's kind of like, well, why didn't you just leave them on? And that gets into like, how much equipment do you have? Like we don't, at UVA, ours mostly live downstairs. We have some for the ICU, but we have more down for the OR. Well, that should be an area of active investigation and interest. I think for my belief is that that's the next step in trying to take the best care we can of this pretty vulnerable patient population. And like I said earlier, their stroke risk, just the aggregate stroke risk of adult cardiac surgery is 39%. Looking at MRI, going back to the discussion earlier about the protection in TAVRs, you may not detect a clinical difference if you have a stroke on your brain MRI, but if you look at these people 5 years later, the higher your stroke burden on MRI after surgery, the worse your long-term outcomes are. So that's another thing I think that we're starting to appreciate.
I am so glad we were able to make this work and get you guys together to have this awesome conversation. I think it's conversations like this that really can drive change in practice. And thank you for all that you do. And it's just wonderful and heartwarming to see like you guys work so well together too, because we all know that there's, it's not always like that in all, operating rooms and operating theaters. So it's great. I know.
That's true. Yep. Thank you for having us.
Thank you so much.
Very impressive team. Very impressive team. Great to meet you.
Yes, absolutely.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.